Welcome everyone to today's meeting. I'll welcome the moderator, Dr. Kagendo Kahunyo, to introduce herself and to introduce today's presenter. Dr. Kagendo?
Thanks, Beatrice. Good evening, everyone. Today we are back to pediatric ophthalmology. Our topic today is management of aphakia in children. So I have the pleasure of introducing Dr. Daniel Mundia. Dr. Daniel Mundia is a pediatric ophthalmologist and squint specialist. And with a wealth of experience, he consults with Kikuyu Eye Unit. He works with Aga Khan University Hospital, Royal Eye and Ear Hospital Parklands, and also has an office at Westlands, Nairobi. So today, Karibu, Dr. Mundia, we are privileged to hear from you. As the presentation is going on, if you have any, sorry, Dr. Mundia, I just wanted to make a comment. As the presenter is beginning, if you have any question or query, please post it on the chat box. It will be on the bottom right on your screen. You can post the chats there, and then any questions will be discussed at the end of the presentation. Okay, go ahead, Dr. Mundia.
Thank you very much for that kind introduction. Today, I would want us to look at this topic of management of aphakia in children. Previously, I think I talked about the whole thing of cataract surgery in children. But today, I just wanted to just think about how do you manage that momentary situation where you have an aphakic eye. And by definition, aphakic eye is one that has no natural crystalline lens, whereas pseudophakia is a presence of intraocular lens. So you want to see how we move from an absence or a temporary absence of a natural crystalline lens to where you have a pseudophakia or otherwise. So this is an eye that is aphakic. It has no lens. The natural lens is out for whatever reason. And now there's this situation where you're thinking, what do I do with this aphakic eye? So the causes of aphakia are many, but most common are surgeries that we do, and planned or otherwise. Then trauma. You could have globe perforations. We have seen corneal perforations where lenses fly out of the eye. We have either total exclusion of the lens, or sometimes it is dislocated, is within the eye, or you have a cataract, a traumatic cataract that you have to remove. Then rarely we may have congenital aphakia, and this is usually associated with other ocular anomalies or systemic anomalies. So we're talking about this situation where we are moving from aphakic to where the lens is in the eye. I'll start with this case presentation, and I want us to keep this in mind as we go along. This is a 10-year-old boy who came to us the other day, June 2025, and he presented with poor vision, both eyes, as also presented by the teachers. He had a history of bilateral cataracts in early childhood, and he went in one of the hospitals in the outskirts of Nairobi. I don't want to say where, at age 2, and was operated in 2017 when he was only 2. He was operated on the right eye, and that's where the eye we can see with a white opacity. And I think he could see that eye. That time he had bilateral cataracts, but having been operated on the right eye, he disappeared and went to school. And it's only in June this year that he came to us. And the vision of right eye, which had been operated in 2017, was 636. The left eye, he could count fingers. And this time he had no glasses. So on examination, we saw that the right eye there was an optic capture, actually one of the sides here, if you can see my cursor, is over the iris is under the optic, and you can see it up to there. Then there was a dense opacity, and it's miraculously, through that opacity, you can see 636. The other one was counting fingers, obviously, with now a mature cataract. This cataract looked like a lamella in the left eye. So we did a surgery on 24th of June, that is about 1 week or so later, where we put an IOL in the left eye. And this time it was asking for 10 diopters, and we put 1 Acrisov from Alcon. I saw him actually yesterday, 2 weeks post-operative, and his vision on the right eye could only go 1 line better with -6.5. This is 2 weeks after the surgery. He can still see through this opacity. The left eye, beautifully done, a beautiful pseudophakia with a postoperative refraction of plus 0.25. He can only see 660. Left eye had a clear media and the normal fundus, but he could only go to 660. So keep that in mind as we go along to see how then, or what could have happened, or how better that we could have managed this boy right at the beginning. So the principle of treatment in these cases of children is, like probably most of us have come across this term, do no harm or non-maleficence, which means that we want to minimize negative impacts of our interventions and at the same time maximize our positive outcomes. So keep this in mind also, that whenever you are faced with these children, you don't want to impact any harm, and you want to maximize on positive impacts. Then we will see what is needed. If you call me in a hospital to do a pediatric cataract, there are a few things I would ask you whether you have in your hospital. And one of them is, do you have anesthesia? And this time I would want to have a safe a general anesthesia, because most of the children, maybe 80% or below 12, we want to do general anesthesia. And general anesthesia means, 1 is the machine itself, a good machine, and 2, the personnel to do it. Then the second one is biometry. Now, biometry here would also comprise of a portable keratometer and an A scanner. Here on the left, you can see that is you don't have to go high-tech, but that is an anesthetic machine. You need a good anesthetic machine and somebody to operate it and somebody to put your children to sleep. Then on the right is biometry. Here we have a portable autokeratometer. You can have even only a keratometer, but portable one. You can see we are doing the child under general anesthesia. And behind it, you can see an A scanner for calculating the IOL. Then we have a vitrectomy machine. Whenever you are thinking of a child, to do a child with a cataract, and you don't have a vitrectomy machine, probably you are also asking for too much, or you are also asking yourself to do harm. Because that child you will see in 2 days, and then the next week, you'll be back to no vision. Then the other thing that you see missing in most of the hospitals is a stock of IOLs. So these are the 4 things that probably you'd want to have before you start the pediatric cataract surgery. Of course, the training and the person doing it, the ophthalmologist, will come in, but of course, you don't want to start even with your training before you have those things. Now that you have your anesthetic machine, you have put the child to sleep, you have done your IOL, you have been given an IOL by machine, and you have a stock of IOLs. The other question that comes in mind of a pediatric ophthalmologist or a surgeon is, what IOL will I put in this child? port power. And this is backed by the fact that we know that the keratometer readings, the axial length and lens diopteric power change with age. So what would I do to this child having these factors at the back of my mind? And many questions you ask yourself: do I give to have a post-operative refraction of emmetropia, or do I undercorrect, anticipating myopic shift? Then, and under that situation, supposing I have a child from Mandera who have come to Kikuyu, and in a week they are going back to Mandera. Would I want to do emmetropia, or do I want to correct? So in that way, the number 2 means what would be appropriate for this particular case that I'm having on the table. Because we have seen that our follow-ups are very poor, and the use of glasses or contact lenses for residual hyperopia is also very poor. They will come back to you in like this child we have talked about 8 years later. They have no IOLs, and they have no glasses, and they have not contact lenses, and then they have developed deep amblyopia. So we have to treat every case case by case, depending on what you anticipate. If a child is coming from Nairobi, the mother is cooperative, you know that you're going to be following up in your clinic, then you can say, yes, I can manage the post-operative undercorrection better than somebody from Mandera. Other factors causing inaccuracies in pediatric IOL power calculation, of course, is poor cooperation during examination. Even when you do a slit lamp or a standalone keratometer, or you are doing your optical biometry, this children hardly fixate, and the machine will not even take. So the poor cooperation is a problem in children, and they don't fixate on the target that you do. Then the other thing is we don't know when we do our keratometer and biometry in spine position, what are the variables? What else do you vary from the formulas that we know? Because the formulas that we have were done on adults who are seated. But of course, we have talked about axial length and keratometry errors that we get. And somebody said that the eye of a child is not a small adult eye. There are differences anatomically. And then, of course, the formulas that we're going to use. There are no children formulas. All of them are adult formulae. So we don't know what effect that has in children. And of course, we don't know what effect our eyewear position vis-a-vis the target refraction has when you have done your capsulotomy and anterior vitrectomy. So probably the eyewear position changes with that, and probably affects your post-operative target refraction. These are graphs denoting the changes in axial length and keratometer with age. And you can see with the axial length, there is rapid change in the first 2 to 3 years. After that, it plateaus out. So the children we talk about are children that are below 2 years, as well as also the keratometer. You can see there is a rapid decline of keratometer readings from 0 to 6 or 1 year. Then it plateaus out. So these are the kids that usually you hear people talking about. If you do such kids, leave them aphakic, then manage the aphakia, then later you can do secondary IOLs. Now we have those facts with us. They are the changes in children. But again, we know that children have very short eyes. Some of them, especially the glaucoma, will also have long eyes. And these are formulae that are given, but of course, based on adult measurements. So these are recommendations that if you have an axial length of less than 20, they are the formulas you use. And likewise, 20 to 22 over Q. and above 26, we use Haigis. These are, of course, what we use and everybody is using. And again, in children, where we use those formulae. Now we are equipped with the fact that the eye of a child changes, and we have the formulas. Then what do we do with these formulas? Let us look at this screen of an A scanner, where we have our child who is asking, our child is 8 months old. We are using our 18.4. Most of our hydrophobic lenses will be around 18.4 and 18.3 constants. The actual length here is 18, less than 19. And we want, in most cases, most of the machines, the target postoperative refraction is set at -0.5. So what would we do with this? We say this is a child that is less than 18, so we are going to use a hover Q here, as we have seen above. We are going to use a hover Q formula, and this child gives us 42. Sorry, my cursor is behaving. So you cannot give, if of course, even IOLs are not available in that range, and we cannot give 42. And we will go back to asking ourselves, what other recommendations can I find that tells me that this child, 8 months, will of course have a change in the refraction over time, axial length and keratometer, and I want to know what to give. And there are methods of determining this, and of course work has already been done by different groups who recommend what postoperative refractive targets that you need. And we shall be looking at one, Inyedi et al., or the popularly known as rule of 7. We shall look at Trivedi, Wilson, and Annan and Drusek. These are the three probably most common recommendations of postoperative target refraction that we find in literature. So to begin with, Inyedi is easy. Inyedi recommends that, or what we call rule of 7, is that if you add the age of a child and the postoperative refraction that you want to gain, then the sum should come to 7. So you have at age 1, you want to have a postoperative refractive target of +6, and likewise all the way down at 8, you'd want to have -1. That is a rule of 7. Somebody else who did a lot of work is Trivedi and Wilson. They are almost like Trivedi, but they had a few changes. Recommends around 2 to 3 years. You can see that they have stagnated a bit, and down there at 8 again. So these are formula that you can put on your chart in your operation room, and probably be looking at them. And the other one is Dahan. Dahan, instead of giving specific postoperative refractions for each age, they worked and came up with recommendations of a percentage of undercorrection, and they grouped them, saying that like 0 to 2 years, you can have a 20% undercorrection, that is 20% of the IOL given for emmetropia. Then 2 to 8 is 10% of the IOL for emmetropia. Then more than 8, you give emmetropia. Or better still, instead of calculating your percentages, you could even go to specifics and say 0 to 1 year, just strike off 6 from the IOL that were being given by the machine by 6. Or 1 to 4 years, you strike off 3, 5 to 12 years by 1, and more than 13 you give emmetropia. There are instances where somebody comes a child is brought and comes in the operating room, already been done the biometry. So what you have on you is a biometry like an adult. It is reading a postoperative target refraction of -0.5. It's also reading direct, giving you direct innotropic power. But this is a child probably of 1 year. So of course there is a manual method of calculating your postoperative refraction, and this says R being your desired refraction, then C is a constant, and this C is a constant given to you that because when you are calculating your postoperative refraction, you are assuming that they have a glass or glasses, and they have a posterior, what is it called? The distance between the eye and your lens, and this gives a constant about 0.65 or 1/0.5. Then IOL power from Utopia. This P is the IOL that has been given the machine, and you are looking for I. What IOL will I put in this eye so that I have a post-operative refraction that I need? I will not bother with this, but you can take it. You can try it in theaters. So when I'm faced with this and I'm not in access of the scanner that was working, then I can use this this formula. But when you have access to your scanner, this is what I do. You have the left side. I'm looking for my cursor. The left side is what we had, asking for 42, having worked with OverQ. But this kid is 8 months. And in 8 months, in our earlier discussions of recommended postoperative refraction, we saw that we need a +6. So you can go ahead straight away and go to desired refraction and put +6 to the machine, and then calculate the IOL. You get exactly what you need to put in that eye, other than going back, other than working out from our formula here. It gives the same thing, but of course, this is straightforward from your machine. So if you need a +2 or +3 or +6, this is where you put it, and then the machine will give you. And most scanners, this is accessible to you can input what post-refractive power you need, or power of refraction that you need. I go back to what we use in Kikuyu. We use the Han and co-workers formula. One, this formula over time has been seen that it doesn't give you as much under correction as the other two of Inyedi and Wilson. This one relatively has a smaller under correction of IOLs. We have used it for a long time, and actually we tested it. That is 2010. We tested it with, and we saw that, of course, like I said, it doesn't give you a lot of under correction. And in this graph, you can see for the first group who are below 2 years, we are only under correcting maybe below 3 diopters. But most of the others also are lying about 1 to 0. But what happens over time is that this by the 6 months, you are all about plus or minus 0.5, and in 1 year follow-up, you are already all around plus or minus 1 of refraction. So it's also bad, despite the small under corrections that you get from the beginning. And probably in our situation where the child goes away from your institution, doesn't come for follow-up, probably this is a better formula to use, because if they went away, you will be assured that they are about emmetropia by 1 year, and we don't have to struggle with the glasses and the contact lenses should they not come back before that time, so that because they are not much undercorrected. Hope you are clear on that. Am I having the audience?
Yes, doctor, you are clear.
You are happy. Okay. So, of course, we have complications of putting an IOL in children. Put a lot of post-operative inflammation. We use a lot of steroids. We have posterior capsular opacities, and that's why we have vitrectomy and posterior capsulotomy. We have displaced or dislocated IOLs, they hit themselves. And of course, the fibrin that forms also displaces IOLs. Most feared is pseudophakic glaucoma because even treatment is very difficult. Optic captures, like we have seen the first case, and opacified IOLs. I'll show you a few. I think somebody posted some picture of opacified IOLs in a patient. These are opacified IOLs that I have found in children. And usually when I look back, these children had been inputted hydrophilic IOLs. Both, sorry, my cursor is not coming. So this is, you would think it's a cataract, but it's patchy opacities of an IOL. This looks like a crystals in IOL. Sorry? Crystals in IOL. And this one is showing an optic capture. So these are some of the complications that we get. We go back to our child at the beginning who had been done right eye in 2017 and left eye we did the other day. And you can see clearly there's an optic capture. The iris is actually stuck behind the optic here and with an opacified posterior capsule. Very little, I don't know how this child sees. We have done a beautiful eye the other side, but of course, 8 years after the first eye, it has grown very amblyopic. That's why you can only attain a refraction of a vision of 660, and the other one has a vision of 624. Of course, this is low vision, but you can see this is a child that would have done better. Should they have had a good posterior capsulotomy, probably an IOL in the back to avoid the optic capture. But I don't think it was done that time. So these are now, we have talked about IOL in a situation where we have a good eye, we have a good lens capsule, and you can input a lens either in the sulcus or in the bag. But there are cases, of course, that you cannot put the lenses in the bag for some reasons. These are done where the bag is lost for any reason, either subluxated lens or dislocated lens, and you don't have a lens scaffold, a capsule scaffold for you to put in the sulcus. These are examples of course, such cases where we have ectopia lentis in muffins, Well-Machisani, homocystinuria, of course, trauma and congenital aphakia. So in this case, you can have scleral-sutured IOLs. You have many examples of that, or you can have Yamane where you don't have to have sutures, or modified Yamane. And in the group, I know there are people who are doing a lot of Yamane and modified Yamane techniques. Then you have iris close. This is where you don't have the support of the capsule like we have previously. So these are a picture showing in the left. These are dislocated red in the AC. This is a traumatic eye with globe perforation. We have had the iris and the lens being extruded, and this eye is now aniridic and anaphakic. And the other one is showing you an iris claw lens put in the AC. This one you can also put an iris claw behind the iris. You can have AC or a PC. What are the complications? Complications of the sclerofixated or ICL? We have corneal edema. Of course, you use a lot of time being there, and sometimes you touch the endothelium. Fatal detachments. You are probably blindly passing needles behind the pars plana or iris. You could have intraocular hemorrhage due to sutures or haptics through uveal tissue. Higher astigmatism, because even the entry points from one side to the other may not be equal. And of course, there could be vitreous, which moves around in the vitreous cavity and which through the IOL to tilt. You could have sexual erosion and lens dislocation, infection, and IOL tilts, that giving a lot of astigmatism. That's as far as, of course, aphakia, where you don't have the scaffold or the bag to put the lens. But what happens to a situation where you cannot even do a sclerofixated, you don't have a bag? And this is done usually in very young children, less than 1 year. In the Western world, like you go into Europe, they say you don't put lenses in under 2. So in that case, you have to use either glasses or contact lenses. Then in our case, you may be faced with an eye that is so small, less than 10 millimeters conio or white or white, actual length less than 17. These are small eye. You don't want to struggle putting a 13 or 12 millimeter wide lens in the eye. You have microsclerophikia. You may have, these children have very lax orthozonics with a small bag. You can't put in the bag and don't want to put in the sulcus. So you have to remove everything and put and leave it aphakic. You have unclear media. You do a lens and you unclear media, don't want to put a lens to float at no place that you know. Then uveitis complication, you don't want to put lenses in the uveitis. This to cause a lot of inflammation. And of course, in many cases, use glasses and contact lenses when you are awaiting elongation or growth of the eye to put a secondary IOL. These are glasses, example of glasses we have in children. Aphakic glasses are best done if you have bilateral aphakia, rarely in unilateral aphakia because of problem of magnification. Of course, if you are giving +2, 10, +15, +20, sometimes we have that. They are heavy and they have these all complications of magnification and aberration effects. Obviously, they are cheap, but of course, it's very difficult for the children to wear. And they have very poor compliance. You can also have aphakia, aphakic glasses with bifocal near correction. Contact lenses, these are contact lenses, a contact lens in an eye. Of course, you have many types of contact lenses. You have daily wears or extended or continuous wear. These are relatively expensive, but the care and hygiene is what we worry about much. Most of our patients are not able to do that, either remove daily or care for that. Of course, this is best done for unilateral aphakia because of, like I've said, glasses will give you magnification effects. And you use them to those that are cooperative. Of course, we are doing that, and courtesy of Zara and Somji, we're having a few kids that have been followed with aphakia. So that is probably what I wanted to present today. I wanted to concentrate on of course, the good eye, that you have the bag and sulcus, but of course we have those other alternatives of sclerofixated ICL, glasses and contact lenses. Thank you.
Okay, wow. Thank you so much, Dr. Mundia. That was a very informative discussion, a topic that many of us don't know so much about.
Hello.
an area with unstable network. So am I back?
Yeah.
Yes, you're back.
Okay, thanks. So yes, as we wait for some questions, Dr. Mundia, the picture you've just shown of the contact lens, that is a soft contact lens.
Yeah,
are you using soft contact lenses or contact lenses?
Yeah, that's a soft contact lens. But of course, we may have gas permeable rigid or soft contact lenses. People have used different types. But for this case, you are using soft contact. I think Dr. Kiage has raised his hand, probably.
Yes, Daniel. Can you hear me?
Yes, I can.
Yeah, thank you for the presentation. I wanted to ask, there's a point where you mentioned about 2 years cutoff for putting IELTS in children. So,
Yes.
but you say something about the developed countries. So, for some of us who are non-pediatric ophthalmologists who sometimes do these cases, what's your advice at the cutoff age when we should be putting IELTS in those children?
My take is that we live in a very difficult environment, and what I do is any child that has an white to white corneal diameter of above 10 and an axial length above 18, I've tried to put an IOL because these children don't come back. At least they'll go away with an IOL. I talked about Western because in Western world, they have been able to do good work with contact lenses, which we don't do here. So I'll put my take is that put an IOL if it is safe to do it in whatever age. I do even 4 months, 2 months, as long as they have a good eye size, I do.
Thank you.
I hope that answers you.
Okay. Okay. Thank you for that, Dr. Kiage. Now let me go to the chat box. Yes, great. Comes back. It's back. It says a 7-year-old with traumatic cataract, anterior lens capsule ruptured, no PC rent. Does the junior ophthalmologist leave it aphakic? That's management
thank
of
you,
traumatic
Victor.
cataract.
Yes, thank you very much, Victor, for that question. And that one has brought me to a topic that I have talked to those who come through me. If you are in the periphery and you have trauma, and especially when you have a corneal perforation, if you don't have a vitrectomy machine, the best you can do is just clear out the lens that is coming in the wound. If you can push it with visco, the better. Once you close the eye, send that patient to where the vitrectomy machine is found with the cataract. Don't try to wash out that cataract. But if you have a vitrectomy machine, you can wash out the cataract. Please do very minimal posterior capsulotomy. Leave as much as possible. If you can do vitrectomy just at the center, leave a lot of scaffold. Then you do your anterior vitrectomy. If you can, if the corneal perforation or trauma is not so bad, you can, and the cornea is clear, you can put a lens. There are those that are ruptured without a globe perforation. You can put a lens, usually in the sulcus, because you will not have the luxury of a bag. But if you don't have vitrectomy, don't wash out that lens, because you bring out the vitreous and it will be a problem even to a secondary IOL. So yeah, but of course, if there's hazy media, leave it aphakic, come back for your secondary IOL when things are controlled. You have a good AC, you can control, and you have a scaffold, and probably the posterior capsule has fibrosed a little more to be tough enough to hold a lens in the sulcus. Thank you.
Okay, that's a pointer to us junior ophthalmologists. Dr. Helen Roberts is asking if you have any experience with the Yamane.
Yeah, I think I have got the question. Is any experience with the Yamane technique? Yes, I do. I don't do a lot, but I know of people that are doing a lot. Jyoti and Jafaji, they quite have a big experience with that, and I have been seeing them do a lot. So probably if you reach out to them, they will do. I think Jyoti does workshops when you have our OSK. The last time in Mombasa, she had a workshop, and it's a place we can attend to see what they do. Thank you.
Okay, Dr. Caleb Momanyi says, thanks, Dr. Mundia, for the informative presentation. I'm not seeing any other on the chat. Does anybody have a hand up? Not yet. Okay. I would like to ask, when you're doing say for these secondary IOLs, when you don't have enough bag, you only have the sulcus, do you adjust the lens power that you're going to put if you find it is if you anticipate you're going to put it in the sulcus?
Not much. In children, you realize you are playing around with estimations, because one, you are undercorrecting, and even undercorrection is not that specific. So I would not. It's not much from bag to sulcus. I will put the same lens that I aim to have.
Okay.
Well, but the only thing I know is that if you're putting if you have a thick, especially when you have the PMMAs with thick square edges, I found that they have a lot of optic captures. So probably just make sure that the optics are under the iris, and probably not dilate the eye too much in the first few days because of that optic capture.
If I'm audible, I'm seeing I've lost my connection.
You're on and off, I think.
Yeah, it's back. Okay. Yes, so it's back. So thank you so much for that very informative presentation. Yes, I'm one of the doctors who works in, Mashinani. So Victor's question is one we had a while back. Yes, so I've been doing the washout and sending to Nairobi, either to
Yeah,
you or to Kenyatta.
it works better for us. We have much better results when you have the vitrectomy, which is not interfering with the one, the anterior chamber. Two, the iris is stuck to the wound. VTS does a lot of harm when it comes to the anterior chamber.
Okay. Okay, if there are, I see no other questions. So let me close the meeting. Thank you so much for your insights. I'm sure everybody has picked a thing or two regarding pediatric cataracts and hopefully even those for adult cataracts. So at this point, I will hand over back to the host to close the meeting. Thanks again, Dr. Mundia. Have a good evening.
Thank you. Thank you, everybody, for listening.
Back to the host, Mercy.
Dr. Mora is supposed to end the meeting. Dr. Mora?
Okay.
Okay, I can't see Dr. Mora. Thank you so much for attending the meeting. Our next CMU will be on 17th. Kindly mark the date and please attend. That is next week.
I saw somebody raise a hand. I don't know whether they had a question. Zalarem.
Thank you, Dr. I'm sorry. I just wrote it. I thought I sent it. So is there any role of overcorrecting children when we put an IOL in the early stage? Any role? Because I saw some people doing some overcorrection. They said it's better we treat the hyperopia rather than treating the myopia in terms of risk of amblyopia. Have you come come across any of these ideas?
No, I haven't come across such an idea. I think the best I can do is to do them emmetropia rather than I overcorrect, because I know that the eye will elongate with time, and that will be even worse overcorrection. And some of these children have very surprising myopic shifts and can go to -20 even with emmetropia at the first space. So I wouldn't overcorrect. Probably if I am stuck, I'll just give emmetropia.
Thank you very much.